Yes, sir. Item 4B is the OPEB, which is Other Post-Employment Benefits Employee Trust Impact Study Plan. We have John as a representative of Foster to give you a update. Council asked in August if we could get a presentation to help council better understand how the actuarial study was arrived at.
Good evening, sir.
Good evening. John Bartz, Senior Actuary with Foster and Fort Myers. I've done quite a bit of work in the retiree health program throughout my career, going through helping clients study benefit changes, the impact, and also giving you some thoughts as to going forward, what's going to be changing in the accounting for these benefits. I'm going to talk about that a little bit because the accounting for these benefits are going to change come Monday, the next fiscal year, the beginning. So we're right on the cusp of a change, and I think you need to understand how that change is going to be reflected with these benefit amounts. So I'll give you a 30-second understanding of what we do as actuaries and what we're required to do to measure these retiree benefits, health benefits. They're very similar to pension. In essence, they're promises in the future to active employees and to current retirees. And basically right now, let's say that someone has a $500 maximum benefit. They're not quite at $500 perhaps, but that's a promise that you will pay $500 per month, just like a pension, for as long as they live. The way the accounting rule says, we take the present value of all those promises using the assumptions set forth in your valuation. And to give you a perspective, the valuation, the last one that was done, which is the basis for the study, was October 1st, 2015. The 2016 is in process, but that's the last valuation that was done. The discount rate that we value all those liabilities was 4.5%. I want to keep that in mind because that was a change. So all these promises are in the future. We discount them by interest, mortality, and whether the person's going to work long enough to actually earn them. Very similar to pensions. So we come up with that study, and as you know, if you've seen your valuation report, you have a required contribution, and this is an accounting terminology, of perhaps $3.5 million, because they say you must accrue these benefits for people even though you're not paying the cash for them now, just accrual accounting. You may pay out in cash for all these subsidies that you have and for other benefits, let's say $1.5 million. These are approximate numbers from the last valuation. So if I'm telling you $3.5 million is your cost and you're putting cash contributions out the door, $1.5 million, you have a $2 million accrued liability each year that just adds to your liability on your balance sheet. As of the end of 9/30/16, that accrued liability was about $10.5 million. So that is what you've already expensed, and it's on your books. You just haven't paid the cash. So now we get, any questions so far, because I'm leading up to the study. Now we're saying, well, GASB 45, I'm going to give you two numbers. GASB 45 is the basis of your current valuation and how we did the study. That is how your expense is done today. 10/1/17 fiscal year beginning, GASB 75 is effective. I'm going to highlight a couple of key differences because they're really key differences. But right now, GASB 45 and looking at your impact, we looked at the group that was in May, you rescinded the $500 cap. It's okay. They had a cap. We're going to rescind it. What's the impact of that? At this point in time, let's call it just a snapshot date. This is, okay, $500, no $500 cap. Under GASB 45, as of 10/1/15, that will increase your liability by, you saw, about $11.5 million. And if anybody, I have a handout which may, if everybody's familiar with the trend rates of why that number gets so high, the healthcare inflation. I also put a graph in there. I decided to graph it to say.
John, do you have one more?
I think I have one more.
There you go.
Okay. Thank you.
In the graph, you can see illustrates a line that says, here's what the $500 per month is capped, and if we remove the cap, the top line, if we did that for every participant in groups 1 and 2, you would see something similar to that. And as math majors, I would call it the area under the curve is what makes up that the 11.6 million. But you can see the trend rates start high, although your inflation may be even higher the last couple of years than what we predicted. These trend rates are not our assumptions necessarily. We use a model developed by the Society of Actuaries called the Getson model, which develops a long-term perspective for retiree health benefits. It's based upon an economic model developed by a professor, and it's used by pretty much all the actuaries doing retiree health. It's the same model we do for the state of Florida. We're the retiree health actuaries for the state of Florida. We use the same model. They modify the first 3 to 5 years based upon their analysis, and then they use a long-term Getson model after the 5 years. We don't have enough data for you to be specific for the first 5 years, so we use the general trend rates starting at 8.75. We do that for every participant, tiers 1 and 2. It came up to 11.6. The expense increase, you can see, is $590. Here's the difference under GASB 45 and 75. GASB 45 says you take that expense and you can amortize it over 30 years. Similar to what you do in a pension plan, right? You amortize it over 30 years like a house mortgage with payroll growth or whatever, using your assumptions. It would increase your expense by $599,000 that year. Your cash flow probably was not even projected to go up because nobody was at that cap yet. The cash flow would increase about 2 or 3 years later when they started to be beyond $500. So you can say, our cash doesn't go up for a couple of years. Our expense goes up $590. Now, we also looked at the impact, and we believe we understood it correctly, of a certain group, and this was in our Impact Exhibit 1, the Section D, where there were certain retirees who were not included in Tiers 1 and 2 because they did not elect to retire at the cutoff date in 14. They elected to stay and drop. And we were asked, well, what's the impact if they had really been able to obtain the Tier 1 benefits and remove the cap on the Tier 1 benefits? In essence, to treat them just like the Tier 1 people. 100% employer subsidy, no cap. What's a delta improvement? You can see under our studies, the present value of those benefits is $2.3 million. And when I say present value, it's not to say, like that 11.6, you're going to pay a lot more cash out than 11.6 over their lifetime, because that's a discounted number. You may be paying $20 million or so. This 23 people is $2.3 million. Now, that is composed of two things. And I want to make clear, it was your intention to to look at both of those. One is they go from maybe a 50% subsidy, 50% employer paid, to 100%, and then no cap. It's like a two-step improvement. That's why it's relatively large at $2.5 million. If you said, keep them at the current level they're at, $8 per year service, or 50% of the employer pay subsidy, which is ever greater, and keep them at that, but then just raise the cap, remove the cap, that impact would be much smaller. A lot of this impact, the $2.5 million, is going from the $8 all the way to the $500, and then removing the cap. And that's a key difference. But that's what we were asked. Treat them like a tier 1 and 2 person. So we also studied if you actually move tier 3 people and just remove the $500 cap. Because right now they're at 50% or $8 per year service. Subject to $500 cap, just remove the cap. They're still at the $8 per year service, or 50% of the active premium, but it's still, they have a cap. We would just remove the cap.
Sir, do you mind if we ask questions as we're going along here?
Yeah, yeah.
Oh, thank you. I'm lost.
Yeah. Okay.
Okay, so let me say what I think you're saying.
Okay.
And then tell me if I'm right or wrong. I think what you're saying is, say, I have 10 employees, and those 10 employees, if they retire today and the cap is removed, I am figuring out the amount, first, their life expectancy, correct? Mm-hmm. And then I'm figuring out the amount that I would pay to them over that life.
Yes.
So person retires at 60, and we expect them to die at 70.
85.
Okay.
Yeah.
We're hoping.
Yeah.
But for mathematical
Yeah.
purposes, let's take a 70 just
Yeah.
because it's easier. And we're saying in that 10 years, this is how much it's going to cost us, correct?
Right. Each year.
Per year, this is how much it's going to cost us, correct?
Well, I went back. For that individual,
Right, for this
from
individual.
60 to 70, each year you're going to pay so much, then we present value those 10 years of payments into
So
the present value
basically, what
number.
I'm doing is I am paying for 10 years in year one?
No. This present value, you present value all those payments. So let's say you're going to pay out $5,000 a year.
Okay,
And if we discount it, you pay $5,000 for 10 years, the discounted value may be $45,000.
okay. So the
Because
discounted
it's
value would
present
be
value.
40,000.
The $45,000 is kind of what we're representing here. It's the lump sum value of all those future promises.
So basically, our liability is $45,000, although it hasn't accrued yet.
It has not accrued yet. You would accrue it and then start expensing it. Now,
Okay,
will
now
you,
explain that.
But after 10 years,
Right,
unless you amortize it over 10 years, all your expensing will equal $50,000 at the end. It may
Correct.
start off small, but you add interest on that $45,000. Your expense each year is the interest cost because you discounted it, so you're adding back the expense back
interest.
into it. So for your example, your present value is $45,000 over a 10-year period is fully expensed. We're going to fully expense all your benefits paid, $50,000.
okay,
So that $5,000 interest is going to be expensed along the way.
okay.
Now,
Understand that.
now, if you amortize over 10 years, that's a good example.
I know. I
They
should-
allow 30 years, which is like drawing out forever. So that is, these numbers kind of represent that present value of a one-time payment. Let's say you could go to an insurance company and say, you know what, we have this cap, we're going to pay $500 max, you pay the inflation.
They wouldn't take that deal.
Well, no. If there was an insurance company out there that says, okay, we did the math, we look at your assumptions, we'll take on all the inflation above 500. we're going to charge you $11.6 million based upon all our assumptions. You give them $11.6 million, if everything works out, everybody's happy.
Okay.
That's what this present value represents. It's a one-time payment discounted to pay for that benefit improvement. It's a benefit improvement. It's a one-time payment. But you can see under the current GASB 45, you don't expense that today.
And how do we handle it?
Huh?
How do we handle it?
You,
If I'm not expensing it today.
You, under GASB 45, you amortize it over 30 years. So you start expensing $590 per year, and then it gradually,
increases.
well, yeah, because you said $599, if that's the level amount, $600,000 for 30 years, you're going to be expensing $18 million by the time you get done, right? If we had no payroll growth, that's the answer. $600,000 per year for 30 years. In total, you're going to pay $18 million worth of benefits. That's under the current. And these represent the current big numbers. Now, what you need to know is these numbers, if we measure them today, as of 9/30/17, and took a snapshot, based upon the new premiums that are going to be paid, which may be higher than we projected, these, and using a different interest rate. We can't use 4.5% anymore.
Right.
We got to go down. GASB is dictating the discount rate to use to measure these. The 20-year AA municipal bond rate. As of June, it was about the 3.9. Of June 30, 2015, it was 3.06. Now it's getting close to 4, but it's not 4.5. Guess what? If I measure this at 4, these are about 6-7% higher, just by that. If I measure it with your new mortality tables, there's another 5 to 10% higher. Here's what you have to be aware of, that come 9/30/17, I call it Saturday, but let's say your next fiscal year, GASB 75 says, look at your total liabilities in the program. They were about $50-some million when we did the last study. You've now added about $12 million to that. If you add another couple of million and brought through 9/30/17, you're up in the $70 million range. What they say is when you adopt GASB 75, you have no options. You look at that number, and then you say, how much have you booked so far? I told you about $10.5 million. Maybe by the end of this fiscal year, maybe that's $12 million. So I got $70 million and $12 million. When they say you adopt it, you book the whole incremental amount on your balance sheet, and now you're $58 million poor as a city, which is happening across the country. You book the entire liability, and then the only expense is the interest cost. Because everything's expense.
Okay.
It's on your balance sheet, and you just pay interest on it. So you're going to have a big hit come Monday. And there's a question of how big that hit is, but the hit will encompass everything that's going to be on these sheets.
You are making me wish I'd paid more attention in accounting.
Well, they changed the rules so much that
It wouldn't help.
it wouldn't help. They keep changing how you do this, so everybody has to go back to school. And us poor actuaries just kind of have to learn. I know more accounting than I know actuarial work now. So it's.
But John, I think what needs to be pointed out is the reason why these accounting practices are being implemented is to give a true picture of the financial conditions of municipal governments and governments. Because these have never been recorded in such a fashion, so you can't figure out the true financial condition of the city.
Right, and that's exactly why cities and states, you saw the Wall Street Journal article, there's $690 billion of liabilities across the country in public plans that are not being reported as liabilities. And that's the whole, it's very similar to pensions. If I
Okay.
recall this, what they did in pensions 2 years ago was 67 and GASB 68. They photocopied that, changed the numbers, and put it on retiree health. The arithmetic is almost identical. Fortunately for actuaries, I learned it once, and GASB 75 is very identical. So they say, all your liabilities, just like pensions,
Yeah.
you had to book whatever wasn't on your balance sheet. Fortunately, the difference on pensions is you have a big funded plan, right? You've already have a lot of assets put aside, and you funded that plan by requirement. In this plan, you have about $2 million toward it, our last recollection.
So,
$2 million toward the $50 million or $70 million. So it's,
so basically you're saying this is the amount that we need to put aside, we would have to put aside each year to fund a pension plan.
well, let's say that,
Well, not,
let's hypothetically say it's $70 million.
okay,
You adopt GASB 75, you book $70 million, that's on your balance sheet. That's a one-time event.
okay,
And the only thing that changes is things that happen during the year. You accrue more benefits, you pay interest, and your expense goes up, and you pay benefits out. And you whittle down that $70 billion or $70 million over 20 or 30 years.
which basically could go up or down.
Well, yes, let's
Well,
say
it's
that.
more likely to go up than down.
Well, it's more prone to go up for a couple of reasons. One is people will live longer than we think sometimes, and the inflation rate for health care is, we use our best educated guesses based upon the economists and what they tell us and what we gather in the healthcare. You can see by experience, that's, your pre-age 65 is going up more than that, maybe double digits. So if it goes up 12% and we assumed 8%, guess what? We have an actual loss the next year, just like pensions. We have an actual loss that you will start expensing over a very short period of time, increasing your expense.
Okay.
So I know I'm not giving you a lot of good news here. I'm looking for ways that say, why would this number be smaller?
Well, we'll take any good news you have.
Well, here's a thought. I want to make sure that that group that we call in Part D is what you intended to do, is give them the 100% paid without a cap, or to keep them at the $8 and 50% paid, because it makes a big difference if that was the impact. It makes a big difference on that 2.4 number.
John, I think council's only decision was on the first 2 tiers, and that was to lift the $500 cap completely.
Yes. That was a $500 cap to remove all of them, the 11 million. Now, what if I was asked, and I've done a lot of this where we carved up benefits, we've improved them. Retiree health is a tricky thing, much trickier than pensions in a way, because pensions, you can have a COLA on it, fixed COLA, even CPI doesn't go crazy. Retiree health, that inflation is just so hard to predict. All the experts are wrong most of the time. And if you're trying to say, well, we want to help the retirees, is there a way that we can help them, but do it in a financially managed way? And my first response would be, we'll look at the cap and improve it, but don't keep it up open-ended. You could bump it up to $600 or $700 a month, and people would be very happy, but it will also buy you several years into the future before you would have to address it again. For example, what would that $11 million be if you said, I want a $600 cap for tiers 1, 2? It's between probably $2 to $2.5 million, based on this study. What if we went to $700? That 11.5 becomes close to $4 million.
So
Now, how many years does that go out? Well, for a post-65 person, it goes out quite a ways. For someone who's 55, I don't know what the premium, if the premium is going to be $550 next year, $700 will still take care of you for several years. But if you have somebody retiring at 48 or 50, that's a lot of years to pay that active premium, and it's bound to be above $700 at some point in the future. But that would have been my recommendation to clients to say, well, rather than just open up to endless, because the accountants and the auditors under GASB make you book all that future inflation. And they say, you have to make an estimate of what it is, and you have to book it today of what the inflation is 20, 25 years from now, and just present value everything back. And I'm saying, well, I don't know what it is. Why don't we just play by ear, play 5 years at a time?
I hope you die.
3 or 4 or 5 years at a time. That's what corporations typically have done, is they cut it back, and then they improve it. They have to improve it in a non-systematic way. The auditors are very sharp with that. They can't say, every 3 years I'm going to improve it to where it was, because then the auditors will say, well, you have no cap if you improve it every 3 years on the dot. But you can say, we will look at it every 4 to 5 years and see where we're at.
And that
Financially, you may be a lot better in 5 years, or you could be a lot worse. But you kept the control on it, and you virtually have protected the retirees for that time period the same way if they had no cap or $700 cap.
And I think, I'm going to speak for everybody, but I hope nobody objects. I think we were all trying to do something for the retirees because they've done so much for the city.
Mm-hmm.
And for some of them, they've taken some financial hits over the years when we were having problems and struggling. So I think the idea was we were hoping to be able to do something for them. That being said, this would be my suggestion, Mayor, is maybe we have a workshop and maybe John can explain it to them.
I think that's where we're headed. We're certainly not going to absorb it all tonight. But I did have a question before we go on with that. You said inflation. Is that including the increased costs of health care?
Basically, it's the healthcare inflation. It's a separate inflation.
Okay, so you didn't mean CPI inflation. You're talking about just health care inflation.
It's, when you look at that front page, we call it trend rate.
Mm-hmm.
Trend rate / healthcare inflation is what we bump these benefits up by, the healthcare benefits.
And Mayor, I'd like to point out that even though we're showing 875, 850, last 3 years, our city's been double digits in inflation and premium increases. So
recent history would show that exactly what he's saying, that it's going to be hard to predict what the future is because of the rate keeps going up.
It's unless you're a giant entity that can swing a lot or have a lot of purchasing power, like the state of Florida. But they spend a lot of money managing it, and they can keep it a little bit lower on their self-insurance. But they have a much bigger base, and they've been able to keep the rates a little bit lower. But again, I thought the 8.75 was high, but maybe not high enough. And that's the whole point is we adjust those trend rates every time we do evaluation because we get the new model and we use those rates. You can see over time, they're expected to go down. Well, I've been doing this retiree health when FAS 106 came out in the public sector in 1993. And that was the same thought. We're starting off high, and then we're going to project them to go down, low. By the year 2000, they're going to be down to 4%. And every year, you just kick the can down and say, okay, now it's going to be low way out here. And so it doesn't seem to go down like inflation has. Mm-hmm. That's what, if somebody has that magic idea of why is healthcare inflation so high, that's what's baffling because who's getting the money?
It's not really that baffling because what has happened is technology that is available now is so more expensive, so much more expensive.
The demand for all these improvements and demand for services.
And then people are living longer because of that better health care, and that increases the expenses along.
And at the end, if you look at the end-of-life expense, is where most of the expense is. And they'll, go to the hospital, you know how, if you're in there a couple of weeks, it doesn't take much to run up $50,000. But you're right. All the
that's why
technology, the drugs, and they're just improving it. So it's sort of like maybe the healthcare professionals they're not getting 12% raises, they're getting 3 or 4. But everything else is driving it up.
Mm-hmm.
So that's what I'm cautioning you is that, hey, we measure these numbers using the best estimates. We'll use when we adopt GASB 75 for this year, we'll have to use that best estimate again, a lower discount rate, and you're going to see that number. And it's going to be on your balance sheet, and what cities are going to deal with is what's the impact, perhaps, on the bond ratings and our ability to borrow money if we have to throw a big unfunded liability onto the balance sheet, where before it was just a footnote. And that's the unknown.
If you will, I'm going to allow a few questions at this point, and then we probably want to look at having a workshop on this. But Vice Mayor, you're up next.
Yeah, thank you. And actually, you kind of segued right where I was going. So if the adoption of this liability, right, so before you could spread it out, now you can't. So you take the whole chunk, but every municipality is taking that whole chunk, barring that there was a policy difference, being that 20 years ago some cities pivoted to not a generous benefits package on the back end or so on and so on. But for cities that are like size, like policy, we're all going to take this hit at one shot. So relative to bond ratings, I mean, is that going to be a drop across the state because everybody do it, or is it going to be an accepted practice that these guys just picked up a ton of liability?
It's going to be it's going to be relative, because I can point out, because we have, I don't know, 75 to 90 clients, retiree health clients, and I would say the minority actually provides a subsidized benefit, like you do. A lot of them just provide access. Pure access. The state of Florida, if you're covered by the state of Florida, what's the cap? There is no cap because they don't provide the benefit. All they provide is access. If you retire, you pay the active rate, and at 65, you pay the full Medicare supplement. There's no liability. If you go to different counties and things, all they provide is access, and that's where the differential.
And if I could also point out that 1 October, we made a policy change for new employees. When they retire, they will have access only now with no subsidy. And we're getting in line with the other communities in Brevard County as well as the county.
And what we see there, and that's has become very common, and a lot of it became common 4 or 5 years ago once they started to see that this liability is going to have to be measured and booked. A lot of them said, we have to, by state law, we have to give them access. That's state law. And if you retire, if you're medical, like right now, if you just said that's all we're going to do for retirees, you still have liability on it, because a retiree may cost $15,000 a year, but you only can charge them $8,000. If the actives are paying $8,000, you only can charge your retiree $8,000, but the actuary says the retiree costs $15,000. That's the implicit subsidy. That's part of the liability you have. You can't walk away from that. That's for everybody has that. But normally when we see that for a county or a city that says we just have access, their expense is generally between 1% to 2% of payroll. Yours is 23%. That's what kind of tells you is that when you have a subsidy and you provide city-paid benefits, that cost for retiree health goes way higher than 1% or 2%. And that's where the relative difference will be. Some people will take very small hits. Some people, Cape Coral, look at their numbers.
We're going to be repeating a lot of this at our workshop. So
yeah.
The purpose of tonight was that we made a decision without proper information on it. Frankly, it was impulsive on council's part at that point. We didn't know how impulsive, though. So if everybody agrees that we need to have a workshop and get into the details of this, we'll just cut it at this point. And unless somebody has some question that they just have to hear tonight, No, okay.
Good.
Mr. City Manager, you will arrange that workshop.
Yes, sir. And John, thanks for traveling up
Good.
here
Yeah.
and presenting
Thank
the
you.
information. It's
We're
very
available
informative.
to, give you more fresh, up-to-date information based upon 9/30/17, which is, I think, what you'll be wanting. Okay, thank you.
Thank you very much.